Good morning and welcome to Social Work 637, the winter semester 2021. And this is week 10, public health. We have a guest with us today. Jimena Loveluck is a social worker and is the health officer of the Washtenaw County Health Department. We shared a bio before class and we'll be able to link the bio in the recording of this video. Jimena, could you welcome and could you introduce yourself, please, beyond what I just said, with a little bit of background?
Sure. Thanks so much, Carrie, for inviting me to your class. And hi, everybody. Very happy to join you. I wish that when I was in graduate school many years ago in studying social work that I could hear from a local health officer. So I hope you find this session helpful, particularly for those of you that are interested in the connections between public health and social work. And as you're thinking about your future career opportunities. So as you've seen from my bio, I really have spent my whole career working in public health. I worked most of those years in the area of HIV prevention and care, but now have a much broader perspective and role in addressing public health issues in our county. And I'm happy to be able to share some of the experiences and lessons I've learned along the way and answer your questions. So also have had a great opportunity, in addition to having a wonderful mentor when I was in the School of Social Work at Boston College, who was a social worker himself. I met him in my first year field placement, which was at a federally qualified health center in an area of Boston called Roxbury, which served mostly African American and Latinos. And he became, my mentor, showing me the role of social workers in public health. He continues to be a mentor today. In addition, I had some great opportunities along the way to sort of strengthen and expand my perspectives on public health and the role of social workers. I had the honor of studying for a few weeks with Jonathan Mann, who was an amazing leader in the area of HIV, and who really championed health as a human right, and really looking at HIV in the context of also health as a human right. And then more recently, I was able to study at the UCLA School of Business, which really helped me through a healthcare executive program, helped me through a time where I was leading the organization, the HIV/AIDS Resource Center, through a merger with AIDS Partnership Michigan to become unified. And so that was also a really unique experience, bringing together people from all over the United States who worked in HIV and healthcare, and who were in many ways going through organizational transitions of different kinds. So,
Thank you.
So anyway, I'll leave it at that.
So that's a lot. And just for context for folks, I actually worked for Jimena like 15 years ago, I think, something like that. And then when I was in grad school for social work and public health, I did 2 field placements, or worked part-time and did a field placement at the HIV/AIDS Resource Center, which is now part of Unified. So I've known Jimena for almost all of my adult life. So thank you for being a good social work mentor for me and for sharing your experience with the students today. So most of our students are training to do interpersonal type work. And I know you trained as a macro social worker, and this class is about health policy. And I'm just wondering if you could describe a little bit of what it means to be a social worker with your training and your mindset in a public health department.
Yeah, so I think, as Carrie mentioned in her lecture, there are a lot of values and areas of focus that are very similar and overlap between public health and social work. And so I would say that in my, training in social work, particularly looking at, community organizing, social policy and planning, which is what I studied, lots of overlap with public health and transferability of those skills and areas. Certainly, we work from a socio-environmental context, which is incredibly important in the world of public health, particularly as we look at the social determinants of health and we think about population health. Also, understanding the important relationship between individuals and broader social systems and the impact that has, the connections that it has, the influence that it has. Those are all things that I think are really foundational to the work, to the study of social work and the way that we are trained. I think also and this is particularly true, I think I found in my work, is that I think we're also in social work, we not only learn, but hopefully have opportunities and training to really navigate the worlds of policy as well as community dynamics, and really sort of the more individual context as well of, family life, for example. The other key part, I think, is the role that we play in expanding access to services, whether that be healthcare services, whether it be other kinds of services. The idea of meeting clients where they are, meeting people where they are, ensuring that we're understanding and addressing barriers to services, that we are facilitating access to services, and that we also act as conveners. And that's something that we very much do in local public health, and particularly as a local health department, that we bring people together who are from maybe different sectors of services or are from different communities. And we bring them together to build partnerships and to build collaboration. I think those are all things that we as social workers learn about and are trained to do, and are really, really important in the work of public health.
Thank you. You talked a little bit about policy and advocacy, and one of our student questions asked if you could talk about a particular advocacy process that you've gone through in your career. It doesn't have to necessarily be in this position, but what are the skills you used and what are some of the steps you took to do the advocacy, and what was the outcome?
Yeah. So one example that I'll use actually spans my work at the HIV/AIDS Resource Center and then Unified, and also the board of health for Washtenaw County. So before I joined the Washtenaw County Health Department, I actually was on the board of health when I was still at Unified. And one of the pieces of advocacy that we worked on, both as Unified, as the organization, as well as our board of health, was around modernizing the HIV criminalization law in Michigan. And so that was advocacy that we did, in a variety of ways. Part of that was organizing visits to the state capitol and meeting with legislators individually. We had legislation that had been introduced, and we also had done some, I know there was a question about community-based participatory research. We had also done some research. We piloted in the Detroit metro area the people living with HIV stigma index, which really showed the impact that stigma had in preventing people from getting tested. And a lot of that stigma was generated from concern about the laws that existed around disclosure. So there was that aspect of direct advocacy. And then I brought that issue to the Board of Health, and the Board of Health provided a resolution supporting modernization of the HIV criminalization law in Michigan. So happy to say that there were changes made to that law. It still didn't go quite as far as we wanted it to, but there were changes made, and really we're able to advocate from an organizational perspective as well as from a Board of Health perspective.
And during this advocacy process, it probably took a couple years for these changes to happen, right? So this isn't something that just happens in a few months, right?
No, not at all. And in fact, I think the state representative who introduced the legislation. I think it got tabled for a session. It had to, kind of be reintroduced. So yes, it was a pretty long process. And you're right, Carrie. I think it was over a couple of years at least.
Right. And so I think that's one thing that students in this class, as we're talking about integrated health policy, depending on where the policy change needs to happen. If it's an organizational policy, it may be less than a couple years. But if it's a state level legislative policy, that might take years. And a federal level policy might take even longer.
Yeah. So and one thing I'll just add about that is I mentioned this sort of local study that we had done. It really made a big difference to the legislators that we spoke to. It really made a big difference to be able to say, we have talked to people living with HIV in our communities, and this is what they have told us. And we have data to show the impact that the negative impact that the current laws have. So also having local data, being able to share stories of people who live in their communities was also really important.
Thank you. I'm hearing from a lot of students that they're not able to find the passcode. So apologies for wiggly video and stuff. I'm trying to reply to folks with the passcode. So thinking about policy and this advocacy process you went through recently, within the last year over the summer, the Washtenaw County Board of Health and the Washtenaw County Board of Commissioners passed a resolution to declare racism a public health crisis. Could you walk us through that process about something that happened locally that was actually one of the first local health departments, I think, in the country to pass that, or to pass a resolution naming that? And I'm not sure if that's accurate, but.
I don't know if we were among the first, but there had been a few other local health departments in Michigan that declared racism a public health crisis before us. But we were, a lot of this was on the heels. What we were among the first to do was to release COVID case data by race and ethnicity at the county level. And, I'm sure I don't need to, everyone knows that, as we have dealt with COVID this past year, obviously it has really highlighted the inequities that we know existed for many years before COVID. But the data that we released, really, we saw that as a call to action, not just for us as the health department, but for, our health systems, for our, organizations, for decision makers and elected officials. In addition, we also were looking at the issue of law enforcement as a public health issue, and obviously with the death of George Floyd and everything that was happening in the bigger context of our country, of our state. We recognize the importance of really naming racism and not only creating this resolution, but creating a resolution that really had some action behind it. And so this was something that was brought up at a Board of Health meeting. We have on our Board of Health, we have a Board of Commissioner liaison as well. And so we were able to talk about not only the Board of Health taking this action and creating this resolution, but also connecting it to what was happening at the broader Board of Commissioner level as well. And so the resolutions are not exactly the same. The Board of Commissioner resolution is a little bit broader, but I think for us at the health department and with the Board of Health, it was extremely important to not only create a resolution that would be outward focused, but also would be internally focused as well. So really calling on the health department as well to do its own, internal work to address racism as a local public health institution, internally and externally.
Thank you. So I'll add a link into the chat in a little bit about the resolutions and share it with the recording of the video. So obviously, COVID-19 has had a drastic impact in the work of the local health departments all across the country, including here in Washtenaw County. I want to talk about COVID-19 as the conversation progresses, but I'm wondering if you can tell us a little bit about some of the pre-COVID activities that the health department was doing, particularly around the disparities, health disparities that exist in our community, and the deep community work that has been happening for years, supported by the health department.
Sure. So Carrie, you highlighted in your lecture some of the, stark disparities we see in our county locally, and some of the data that reflects that. Part of the role of the health department and any local health department is to regularly do community health assessments. And so if you look at our website for many years, going back every 5 years, we've done what we call Health Improvement Plan survey, or HIP survey, which is kind of a broad look at some key indicators of community health and community health assessment. And so that's an ongoing role and responsibility of a local health department. It's obviously incredibly important in public health to identify those public health priorities. But what we were seeing, of course, was in that process, particular areas of our county or particular populations where we saw greater health inequities. And so as a way to dive deeper into the root causes of those health inequities, we started working and partnering with local community members, local community leaders, to look at 6 different areas. Some were geographic areas, some are population kind of defined, but really to delve deeper into the root causes of those health inequities, and most importantly, to really bring community members to the table to lift their lived experiences and community voices, and to share decision making around identifying community priorities, and of course, most importantly, identifying community-driven solutions to address those health priorities. So we've been doing community engagement work around these issues. We have a community voices group that meets on a regular basis and had been in existence for years before COVID, to really work on health inequities from a more community-driven, grassroots kind of standpoint. And then also more recently, we created Health for All Steering Committee, which was going to be driving our community health assessment process. Unfortunately, that's been set aside a little bit because of COVID, but Health for All is still a group that meets regularly. And you'll also see that we created a website, a Health for All website, where you can find lots of important resources and data related to community health and various community health indicators.
Thank you. So this is a little bit related to a student asked about community-based participatory research, and you mentioned it a little bit before. And I know that over the years, there's been a lot of data collection and data analysis, and I know that a lot of folks are really wanting to move to action. And so how can you give an example of any sort of action that has been taken based on data that was collected with the Community Voices Leadership Group or the different neighborhood work, a specific action that was taken or outcome that you could talk about using the data that you just mentioned?
Yeah, I think so. A recent example is we got funding through the Governor's Task Force on Racial Disparities, COVID-19 racial disparities, for a rapid response initiative project. And that was in the fall. It was very quick turnaround, but we worked specifically with community members, with members of our Community Voices group, as well as other community health workers, to engage with community members and get their perspectives and feedback on what their views were of the anticipated COVID vaccine that was under development. It hadn't been made available yet, as well as flu vaccination. And so we took a lot of that feedback that we received from those interviews and gathered from their feedback to establish not only community flu clinics in the fall, but also to develop specific messaging that featured some of the community members themselves, develop specific messaging to encourage people to get their flu vaccine, to follow the public health guidelines around COVID prevention, and really developing a message of caring for your community. That really was informed by the feedback that we received. And then, of course, we've been using that feedback as well in implementing our community vaccination clinics and working in partnership with community groups to really not only continue to craft and refine the messaging around vaccination, but to actually help with outreach, specific outreach and even appointment setting for community members to get their COVID vaccine.
So we are starting to talk a little bit more in the COVID world, which is obviously a big topic in your life for the last over a year now. So what has the impact of COVID been on just the health department in general? So, you're the leader of the health department. There's a lot of things that you're responsible for. And now there's this huge amount of extra things added on. So tell us a little bit about how you've had to make some adjustments to address this.
Yeah. So just, in thinking about my role as health officer, so I really officially became health officer about 5 months before we started dealing with COVID. So most of my time as health officer has been addressing COVID, and the impact on the health department has been, just tremendous. Obviously, we, for public health and emergency preparedness, we're like on the forefront of the COVID response, and we basically have had to pretty much redirect all of our staff to support COVID response efforts. So, Carrie, when you talk about, the mandated versus non-mandated services, we are, obviously having to keep up with some of those mandated services. The state has alleviated some of those requirements because we're all dealing with COVID. But yeah, except for what is absolutely essential that we continue to provide, we are all focused on COVID efforts. So our environmental health staff, our sanitarians who normally do restaurant inspections, they've been pulled in to do case investigation and contact tracing, and they're working in vaccine clinics. So it's obviously redirected the whole health department. In addition, we've had to hire additional temporary staff to supplement our workforce, because clearly the capacity that we had was not sufficient for addressing COVID for as long as we've had to do that. So it really has been a huge change.
And, I think we've talked about this in Social Work 637, that in the United States, health services are very decentralized. Some are provided by public health departments. Some are provided by healthcare systems. Some health services are provided by federally qualified health centers. And all of these have different funding streams. And the way that the COVID response has been rolling out from the beginning, first it was trying to get enough testing to even know where COVID was having waves of infection. Then, of course, there's the typical contact tracing and quarantine process. And then once vaccines got on board, that was also delegated to state and local health departments. And so now state and local health departments, but particularly local health departments, have to continue to do that testing and tracing, and now are also distributing vaccines. And so are some healthcare service providers as well, medical care type delivery systems, including pharmacies. But it's not that you've stopped doing testing and tracing. You're doing that and also doing vaccination.
That's
So
right.
it's,
That's right. And cases are going up. So we've had to, again, sort of figure out, okay, now who we need more people to go back to case investigation. It's constantly, yes, it's really challenging. And Carrie, one thing I'll just highlight also, because I know you did a great job talking about funding and some of the challenges related to funding. So just to give you an example, many of you are probably familiar with the CARES Act. Well, that provided, really important funding in the first kind of wave of COVID response to local health departments. But Washtenaw County, for example, did not get CARES funding directly because our county, the population of our county is not big enough. It only went to counties that had 500,000 or more residents. So we had counties next to us, like Wayne County and Oakland County, that were doing all of this amazing work, especially standing up drive-through testing sites and, providing all of these resources, when we in Washtenaw County actually didn't have those resources. And we as a health department actually didn't have funding to do testing. So it was a really difficult challenge, not to mention that, those funds had to be used by the end of last year. It was a very quick turnaround time. So part of what happened for us also is that CARES funding for us, it really came through the state. So we had to wait for it to get approved and sort of processed through the state, through the Michigan Department of Health and Human Services. By the time we were awarded the funding, it was already, I think, July. And some of that funding had to be used by September 30th. So funding mechanisms also are particularly challenging in times of emergency as well, especially if you're not able to get, direct funding. And just going back to advocacy, I did a lot of advocacy with NACHO, the National Association of County and City Health Officials. And I talked with our legislators in collaboration with NACHO to say, please, in the next package, think about funding local health departments directly so that we don't have these kinds of delays, so that we can get the funding we need to put it into, services and get it out to the community as quickly as possible.
So this, the response to the COVID-19 pandemic has been characterized as an emergency response. And ever since September 11th, 2001, there was more focus on emergency preparedness in the world of health and public health departments. And that was 2001. And then in 2005, there was Hurricane Katrina and the response, or, lack of response and coordinated response that happened in Louisiana and the Gulf region. And there has been a lot of movement at the federal level to roll out emergency preparedness, and that is administered often through local health departments. And even here in Michigan, we have regions of emergency preparedness that don't happen to overlap in geography with other types of regions for planning. So what is the type of planning in pandemic of an infectious disease? What are the types of emergency things that were being prepared for by the health department before this particular emergency?
Yeah, that's a great question. And I think, it's so interesting because I think in general, I'll just say, I don't think the public, I'll just say the general public, I don't think they have thought much about public health in their day-to-day lives or the work that local health departments do. And if there's any, positive side to COVID-19, I think, certainly public health has become a much more important source of looking at where we need to invest and kind of improve our public health infrastructure. But in terms of sort of ongoing emergency preparedness, typically, we always had part of the requirement is always to have a mass vaccination plan. So When we had H1N1, so that's always mass vaccination, and having a mass vaccination plan has always been a requirement of our emergency preparedness planning.
Mhm.
But the other things that we focus on are, natural disasters, right? As well as other kinds of biohazard kinds of incidents. And our emergency preparedness manager is always connected to other emergency preparedness managers in the region that you mentioned. So there is there are regional meetings that happen on a regular basis. And also in our county, we have an emergency operations center as well. And so every year as a county, we do a county-wide emergency operations exercise. And so part of it also is doing exercises, and sometimes it's done with hospitals. Sometimes it's done kind of county-wide, but also doing exercises so that we're all clear on what our rules are, how the incident command structure works in the case of an emergency. And we in public health, at least for the county, when we have when the emergency operations center is activated, public health has 2 seats at that planning table and response table. And we actually are there representing not just the public health department, but we're there representing hospitals as well and our healthcare systems. So again, talking about the integration, we are there representing various healthcare institutions.
Mm-hmm. And there's different kind of emergency preparedness requirements for a local health department compared to a certain type of health system, like a major health system as well.
Yes, and the health systems each have their own emergency preparedness people as well. Yeah.
Right. And it's important to know, who's who, and even there's different kinds of emergencies too. There's kind of a community type emergency where it might be a natural disaster or, an infectious disease pandemic, but then there's very localized types of emergencies like chemical spills on highways and things like that. So there is different types of preparedness we need to plan for, and then there's different responses as well. A question from a student is about the A20 plan and the resilience hubs. Is the health department involved in that? And I'm not sure if you're familiar with that. I don't know exactly what A20 is referring to.
I'm not sure what A20 is referring to either.
Okay.
Sorry.
So that's okay. For the student who asked that, if you would like to add more context in the chat box, we can bring the question back. Or you're coming off mute, you're welcome to.
Okay, I didn't know what the norm is. If we could do that. Hi, I'm Julie. I thank you for speaking as well, Jimena, for being here. It's super interesting. I know, so A20 is Ann Arbor's plan to go carbon neutral by 2030. But I think part of that effort is creating localized resilience hubs to either climate emergencies that could happen. If, for example, there was like what happened in Texas just a couple weeks ago, where like county services couldn't get through for like 5 to 7 days. And so they're creating like these localized resilience hubs for emergency preparedness. And I was just wondering, because you were talking about emergency preparedness, if you guys are connecting in any way to create support systems ahead of time, and like kind of, I just didn't know if you guys were involved in any way.
Thank you, Julie.
Yeah, that's a great question. I think that, I can't say that we've been involved in those conversations recently, but I will say that our emergency preparedness manager has done a lot of work around climate change and connecting to both county and city officials around climate change and emergency preparedness around climate change. So that's an area that, I think I had a long list of things that I wanted to start working on when I became health officer, and building our work around climate change was one of those. But unfortunately, we haven't been able to do much given COVID, but certainly an important aspect to emergency preparedness for sure.
Thank you. So I was bringing up emergency preparedness a little bit because in the future weeks of this class, we'll be talking about crisis services, and there's a little bit of a different way of thinking. You know, public health is very focused on prevention and preventing people from getting to the crisis stage. Whereas in a future class, we'll talk about crisis services and how do they fit in the whole spectrum of services. And, you know, it's a different type of planning that needs to happen for emergencies and crises, and a different type of capacity that's needed. You know, capacity needs to exist before the crisis happens. And often with public health, we have funding streams that target particular health issues. And then once that health issue, the data starts showing that there's decreasing incidence or prevalence of certain conditions, they might decrease funding. You know, the people at the federal and state governments who appropriate funds to tackle these issues. We've seen that with tobacco use. As tobacco use goes down, funding for prevention goes down as well. And it's kind of a constant thing that's frustrating to people in public health, where, you know, part of what's working is that we had a sufficient amount of funding to tackle that. And so it's just a different way of thinking as far as funding goes. So thinking about COVID-19, there was some questions around, you know, the staffing programs and the way you've had to change your work. Another question related to COVID-19, you know, in your opinion, what has it shown about the way that public health is organized and financed in general? You know, there's pros and cons of having things funded in such a localized fashion where every health department can do something different. You know, in this COVID-19 situation might be different from doing water inspections, you know, the localization. So can you talk a little bit about pros and cons of the way that local health departments are so localized and different in context of the COVID pandemic?
Yeah, well, you know, needless to say, from, you know, from the national front to the state front to the local front, it's, you know, it's been challenging in so many ways, because we have public health systems that are not connected at not just the county and state level, but then at the state and federal level. So it's a very disconnected system, as we've learned. I think as local health officers, you know, we have a group, an organization that's made up of the local health officers. And so we have an opportunity to talk often and share experiences and challenges. And I think that, for example, when it comes to the Michigan Public Health Code, I'll talk about that a little bit. So in Michigan, both the state health department and local health officers have parallel authority when it comes to the Michigan Public Health Code, meaning that just like we've seen with the state, they can issue, you know, MDHHS director can issue epidemic orders that are statewide. Local health officers have similar authority in their county or jurisdiction to issue local orders. Now, our preference as local health officers is always for there to be a statewide order, because otherwise, to have one county doing something and a different county doing something different, even though they might be right next to each other and you have people traveling back and forth, obviously not the most ideal response. So that's one example right there where we've really tried to coordinate. So I've worked with especially health officers in Southeast Michigan to really coordinate if we are thinking about a public health order, kind of talking through that together, talking through what that's going to look like. So that is one example of where we've really seen some of the challenges with having that kind of local authority and state authority, and it not always being this, you know, sort of coordinated. I think the other piece is around surveillance systems, and, you know, the data and sort of public health technology piece is really challenging, and that's something that I know the state is looking at, obviously, of reevaluating and putting more investment into. But we see that in that, for example, we have a statewide immunization registry that we're required. So we're required to, report every COVID vaccine dose that we give through that immunization registry. The VA hospital has been doing a phenomenal job vaccinating vets and their caregivers, and now they've been approved to vaccinate spouses as well. They don't use that registry because they are federal. They use a different system. So when we are looking at data and looking at our vaccine coverage, it doesn't include the vaccination that's been provided by the VA. So those are just a couple of examples of where that sort of decentralized public health authority is challenging. And there are some benefits to it, of course, as well. But in a response like this, that is so expansive, that is so lengthy, so ongoing, has so many different kind of facets and stages, there have been more challenges, I would say.
Yes. And so, is this pandemic kind of illuminating a possibility for more standardization or more consistent payment structures, or, across local health departments, or better communication? Is that what I'm hearing you say, that there's a little bit?
Yes, a little bit. And I also think that, I think that there's often been a really big separation between what we consider, traditional healthcare and public health. And while we have always worked with our health systems and collaborated with them, I think this also has, the pandemic has also really shown the importance and the need for health systems and public health to work even more closely together. And if we think about, what are some of the biggest predictors of COVID serious illness and hospitalization? Of course, one is age, but another one, for example, is obesity. And so from a public health perspective, obesity is something that, we often think about as, in our work around prevention and health promotion. But obviously, when we look at, not just chronic disease, but here in an emergency pandemic, and we see that some of these chronic conditions or underlying medical conditions are putting people more at risk for hospitalization and death, I'm really hoping that we have kind of a new partnership or a strengthened partnership with our traditional healthcare providers to address population health, really. And to think about our unique roles, but how we can complement each other in addressing these population health issues, in addition to holding health systems also accountable for moving the needle when it comes to health equity.
So thank you. Thinking about health equity, what do you see as some of the next, the key important next steps to achieving health equity? And you could talk about here in Washtenaw County or more broadly in your response.
Yeah. Well, I think certainly we know that data and transparency around data, reporting data as much as we can in a disaggregated, way, highlighting, race and ethnicity, as well as other demographic characteristics. I mean, that obviously is incredibly important. And our ability to really have real-time data is so important. So I think that's a critical piece, and that's something that we, locally and statewide still need a lot of improvement around, and strengthening of our data collection systems and reporting systems. I think the other thing in terms of health equity, as I mentioned, we've been doing a lot of work around health equity using a community engagement model. And I think that approach will only be strengthened as a result of COVID-19, and is already being strengthened, I think, with our health department, and I think with many other health departments around the state. I also think that community health workers play a critical role to not only increasing access to healthcare, but really addressing health inequities. We have community health workers in our health department. We also obviously work very closely with the Washtenaw Health Plan, which is housed in the health department, and they have community health workers, and really viewing that model as a model that really also builds bridges between public health and traditional healthcare. So I think strengthening the community health worker model is also incredibly important. And then just, ongoing cross-sector partnership and collaboration. Clearly, as we look at social determinants of health, that is not public health alone to address, but so many institutions and organizations and community members in our county.
So you talked a little bit about, you mentioned social determinants of health just now, and an example of a social determinant might be internet and broadband access in order to continue health services remotely during a pandemic or to schedule appointments. What is the thought or any action of the health department to address broadband within our community, within our county? There's a student question about this.
Yeah, there's actually been a county-wide effort, and there's been a broadband group that has been working to look at broadband access countywide. So certainly, obviously, very connected to public health and access of health services and other services. For us, I think we're looking to see what happens with the American Rescue Plan. Because we know that there's a significant amount of funding that will be coming to Washtenaw County, not to the health department specifically, although hopefully some will come to support ongoing COVID response, but there will be a significant amount of funding coming to Washtenaw County, and part of how those funds can be used are for infrastructure, building infrastructure, strengthening infrastructure, including broadband access. And I know that that's been a really of real interest to the Board of Commissioners, as well as obviously many other county groups and organizations. So I would anticipate that we're going to see more work around that. And for us, we recognize that, for example, with vaccine scheduling, it's incredibly important for us to, as much as online scheduling is convenient and accessible for some, we always have to think about people who don't have those resources or don't have access to broadband. So we still are providing assistance to people by phone. And doing as much outreach as possible as well, so people know where to go for information, even if that's their neighborhood association or their local church. So making sure that people who are trusted community messengers have information and can get people connected to the resources they need.
And that includes in multiple languages too. I
Yes,
think in
absolutely.
Washtenaw County, we have populations of folks who speak Spanish, Arabic, and I think there's a large number of people who speak Mandarin, Chinese. Are there other languages here that the health department really does a lot of work with non-English speakers? I
think those are the main ones that you hit upon, Carrie. And that's something that we've, been doing also. I mean, we've always had materials developed in other languages, but as part of emergency, when you're talking about emergency response and emergency preparedness, so important to be able to communicate effectively and get people information in their language. And so that's also something that that we have worked on from the beginning. And sometimes we have in-house translation capacity to some extent, but there are some languages for which we need external assistance. But that's really critical. And also by phone, being able to use, if needed, a translation line. So that people, if they are communicating with us by phone, and someone doesn't have the capacity to speak their language, we're able to ensure they have information that they can understand in their own language.
Mm-hmm. Well, we are getting near the end of our time today. And I was, just in the world of social work, since it's mostly social work students listening in today, what is something that you wish you learned more or got a chance to study more when you were in graduate school for social work?
Gosh, that's a good question. I think, I've done so much work, kind of being involved in organizations or, directing organizations that are going through significant change, whether that's a merger, whether it's, responding to a pandemic. I do think that they're, sort of having more, organizational behavior, change management kind of opportunity to learn more about that might have been helpful. I think also, in public health, we deal with so much data, and I don't think that social work necessarily should offer epidemiology classes, but really, statistics and data management. I mean, those I really spend a lot of time poring over data and trying to understand data. And luckily, I have a great epi staff that help me. But that's also another area that I don't feel like I was able to study a lot in social work.
Yeah, I have heard that about the data and biostatistics and epidemiology and things for more macro type social work in the future. But I think it could also be helpful for even working in clinics or in the healthcare setting. It is useful to have an understanding of that. And then, of course, one thing that social work instructors, we often tell our students that even if you go into more of an interpersonal type work in the near term, ultimately, we're hoping to be training you as leaders, and you might find yourself in a leadership and more management position. And so these macro classes around organizational management, remember them and don't throw away your materials or don't delete your materials, and you might come back to them in 15 years. So what other, things do you think future social workers should know? What are some things as they're going through their education and field placements, what kind of advice do you have for social work students?
I think, so I think one of the things I feel like is so great about the field of social work is that there are so many areas where you can work, so many opportunities where you can make a difference and contribute. And so I think that I would say don't feel limited by looking at only certain areas of work or kind of really thinking about the traditional social work role. I think I've seen social workers in just so many aspects of the field, and it's really expansive. And so I would say don't limit yourself to what you might think of more as traditional social work roles. And the other thing is just take the opportunity every chance you get, whether it's your field placement, whether it's your classes, network with other social workers, learn about, what they do, what their roles are, the work that they do. If there's one thing, I'm constantly learning. I'm constantly learning from others. And I think that, just being open to learning and hearing about other people's experiences is really important. And I have to say, I mentioned early on that I had a great mentor. And so if you find someone who, has, wow, that's what I want to be doing, or, really has made an impression on you, find a mentor, because that's been really instrumental for me. And it's been a lifelong relationship, which is also really rewarding and wonderful. So finding a good mentor, I think, also is really important if you have that opportunity.
Great. Well, thank you very much for joining us for this class. There's 16 sections of this class, and so we're recording this to share with the sections that are not happening Monday morning at this time. So thank you. I really appreciate hearing from you in this venue, and I think the students do as well. So thank you again.